Welcome to At the Nurses Station, a podcast for nurses about everything except the patients. I'm Sam. Kelly's here. She's
Hi.
Looking gorgeous because she didn't wake up 7 minutes ago. I'm looking rough because I did. But
Yeah, you worked last night, and I had to call you, and you were like, "Hello."
Oh, that's so horrible.
I feel bad.
Oh, don't feel bad. I should have been awake because we had planned this and then I got my time frames off. So it was my fault entirely. But how are you? How's the first part of this day in the waking world been?
It is good. I had an interview right before this. I think I talked about it in the last episode that I was applying for just like a little per diem job on the side. Just, because my life isn't crazy enough. Why not throw in another job?
I think that you'll be good at this one, though. I think that it takes a special kind of nurse to do this and do it well, and you're one of the ones that can do that. So it'll be good.
Thank you. Yeah, it's for forensic nursing. So, I'm excited. You asked me how it went before we got on air, and I was just like, meh, it was fine. I don't know. After being a nurse for 20 years, I'm like, take me or leave me. This is who I am.
I cannot imagine that personality type of you came from nursing. I have a sneaking suspicion it has always been that way for you.
No, when I was younger, I used to get nervous, like before interviews or when meeting new people. I don't get nervous anymore. I'm just like, hi, it's me.
I will say, I feel like we should talk. I think we'll do an episode about like who we were before we were nurses, because I was neurotic and so if you think I'm difficult to deal with now, before nursing beat the control freak out of me. Yeah, I was a lot. That's probably why my parents put me on meds. So.
Oh, well, there you go.
Yep.
I could see that. Were you a little OCD? I had a little OCD in my early 20s.
No, not anything like clinical like that. I was just like a raging biatch when I started my period at like 15. And it took a while for that to wear off.
Well, when you said like you were a control freak, like I used to be really weird. Like I couldn't let my food touch. And I would count stairs all the time. Like really random stuff like that like there's no room in my brain for that nonsense anymore.
Counting the stairs when you walk up them is not OCD. I think that's just like a natural thing that your brain does.
No, I don't think it is because I don't do it anymore. I think that's like a controlling thing. Do you still do it?
Yeah, there's 8 stairs and when you come up from the parking garage before you turn.
Okay, so you need to start asking people because I used to think it was normal too. And then I found out most people don't do that. But it's funny that you do, and I used to, and I had to let it go.
What? Oh, okay. No, I meant more controlling in that, like, I couldn't tolerate other people's behaviors that I didn't think were correct.
You used to be worse than you are now?
Yeah. That's how I found myself on birth control in high school, because the doctor said it would chill me out and fix my acne. No, water polo did that. And then getting married and becoming a nurse and becoming a mom. I don't know that it fixed it. I think it just rechanneled it into different areas.
Yeah.
But you can't.
Oh, I was just going to say, I think we both have a little bit of that inner aggression in, though, where we have to find some way to get it out. We worked together the other night.
2 nights.
Yeah, we worked 2 nights in a row, which was super fun. I stayed late. We had like the best team of people. It was one of those like, we can handle anything. We just laughed and had a great time. But I had this really crazy teenager who threw underwear in my face. And I came home and I was so amped up because I just felt like I needed to fight somebody or do something. And if I could have gone and played water polo right then, I would have been amazing.
Amazing. You would have gotten kicked out as many times as I did, probably.
Yeah.
What I really appreciated about one of those interactions you had was hearing you say, "Excuse me," all the way at the desk. I was like, oh, it is on. Mm-hmm. Okay.
Yeah.
Yeah. You really just can't, as an ER nurse, it's what is it? It's you really just can't control everything. There's this idea that you want to and that you should, and then you just realize you can't.
Mm-hmm.
But I do. Yeah.
Coming from ICU first, you start in that like you can control everything and super neurotic, and then you go to ER and it's just like whatever.
Yeah,
you got to go with the flow.
Maybe that's why we do ER similarly. I think I have like the generational ICU-ness in me, and then when I found the ER, I was like, oh wait, I don't have to be perfect all the time. I actually kind of like this. This sort of feels good.
Yeah.
I do have a question for you, though. So 2 nights in a row, a total of 16 hours that we got to work together, I think, which is way fun. Did you notice anything different about me in any of those shifts?
Well, apparently I should have. Is it your bangs?
Nope. Although my hair was on point that first night, for sure.
Did you wear a different color?
Nope.
No, I'm sorry.
My jacket was new.
But it was the same color as normal?
Yeah, but it was I got a new gray one off of Poshmark. I've been waiting for you to notice.
Oh,
yeah.
But it's the same but it's the same as your old gray one?
Well, yeah, because that's the right color.
And how am I going to notice?
Because it was a new jacket. Like,
I'm so happy for you.
Okay, thanks. I was excited that I found it. But I've been waiting to wear it to work with you to see if you would notice that it was a new one and not the same worn one that I had. But you didn't, so right.
Work life failure.
Yeah, bum deal. But no, we had a good weekend. It was a lot of fun. I don't think that we had what we wanted to talk about today. We didn't have any patients. Well, while I was there, I think one of the days before the night shift, you had maybe an unstable patient, right?
Yeah. So it wasn't my patient, but it was a baby came in like, a year and a half old, I think, and had been vomiting for 3 days. But we could not get a line in this kid. And I'm talking like the best of the best trying with ultrasound, IV therapy, even with ultrasound. And she just kept getting sicker and sicker, where you're sitting there poking and now we're not responding. And she's kind of grunting and saying like, we just need an IO to get fluids. But her vital signs were totally stable. So, when you have that patient where if you look at the monitor, they look fine. But if you look down at the bed, you're like, this kid is sick and we need to move our booties.
What makes you less comfortable, having the monitor having your numbers look okay and your patient look like crap, or the inverse?
Oh, definitely monitor looks okay and patient looks like crap.
Yeah. Okay.
Because we've been told our entire lives, right? Kids are okay until they're not.
Yeah.
And I don't know that we always see that. I think that a lot of times they look not, or their vitals are not okay, but people maybe just don't recognize them. But I think they can have normal vital signs for a really long time. And you can look at them and say like, they are going to crash here real quick.
I think we are more tolerant of a range of vital signs in kids than we are in adults as well.
Oh, for sure.
Yeah.
Yeah. If you have a heart rate of 220, but you're a screaming baby, I don't care, even though it's abnormal.
Right. But I guess that's my point, is like, we don't care, but that doesn't necessarily mean there's a higher chance that something could still be wrong, even though it might still be justifiable. Like, it could just be that your 13-month-old is screaming and has a fever, and that's why their heart rate is 200. Or it could be something else. And in that moment, there's too much noise to differentiate.
Yeah. I
Right.
think that's where your clinical assessment skills come into play. Right? Because if I have a tachycardic baby that's also tachypnic, then I'm more concerned than just a tachycardic, not tachypnic baby. Like, you have to know the little nuances, like, of why are you concerned?
Yeah. I think I probably agree with you about having an okay monitor and a crappy looking patient, I do sometimes feel like providers easily brush that off. Not necessarily any ones of ours, but I struggle more to like advocate that I am uneasy about something if my monitor looks good. But I also don't like it when when my vital signs look bad and my patient looks okay, that I just feel like something is off. And that also makes me nervous because especially kids, can look good for so long until they're not.
What would you say is your go-to like assessment? Like if you had like 2 seconds, let's say 5 seconds, what are you going to assess to see like sick or not sick?
I don't know that I
guess it depends, right? I mean, it's the across the room assessment.
Color.
Right? Yeah.
The number one thing I want is color.
Yeah. Are they pale?
Or gray?
Or cap refill?
Yeah. I mean, I want to see chest rise, and then I look at their color. And those are I guess if there were 2 things that I subconsciously look at in like everybody, it's probably those 2 things. And then next will be it's hard to piece it apart. I don't know that I've ever really tried in that necessarily, but I think the other thing I would look at are their eyes, but just for not anything that you would teach somebody or that is like on a test, but I'm looking for what's there. Are they awake? Are they alert? Are they cloudy? Are they glassy? So mental status, I guess, is what I'm trying to discern from them.
Right. And in babies or kids, that's more difficult to assess. So like if you're a first nurse and you're like the first person to see the patient, you have to go out and actually look. And if they're sleeping, what I'll usually like listen to them or tickle them a little bit down their side. If they wiggle or open their eyes, great. But I feel like you do those minimal things to see where they're at. What's interesting when you said eyes is that really sick baby, I opened her eyes and her sclera were almost like a lavender color.
Oh.
Which was so bizarre, right? I was like, I don't even know what's going on, but she looks like crap. And so, of course, I'm going to open her eyelids, look at her eyes, and they were almost lavender. And I still don't know what that was. I mean, I don't think she had hemoglobinemia or anything weird like that, but something wasn't right. And it was a dark-skinned child, so that changes things a little bit too. Whether that means more pale or, whatever.
It is hard. The only way that you can really get that kind of skill is, I think, by the numbers. Like you just have to see patients for a certain, like kind of why Dr. Rochelle was talking residents and doctors train for so long is just the sheer numbers game. You just have to do it so many times to learn what you're doing.
So what do we tell nurses that like don't have as much experience? Would you just say go into every sick patient and look at what they look like? Like you don't even need to help, just put your eyes on them when all the advanced nurses are in there freaking out about it?
I don't know that I would put the sentence together like that, but yeah, that's what I did in the hospital that I like grew up in. And I knew a lot of people, so it wasn't, I mean, I guess I kind of had like a little more grace when I would just like show up. But yeah, you just have to go be a part of stuff in a way that doesn't get you kicked out. So that's the social aspect of it, right? You have to figure out that way that it's going to be allowed, especially if you're in a bigger facility. And then I think the other key thing for any new nurse or new to what you're doing nurse is you need to find trustworthy people that when you come and ask them to do your IV or you come and ask them to assess your patient, you need information out of them. You need to go in with them. You need them to tell you what they see, and you just need to catalog all of that. I remember our oldest, and bless him, most senior nurse, when I first started working with him, I had a pleural or oh my gosh, an effusion in the heart and the sac in the heart.
Uh-huh.
Cardiac. Oh,
Tamponade?
She wasn't tamponading necessarily, but I think she had some cardio.
Now we're both.
I'm so sorry. I'm struggling.
I just have myocarditis in my head, but that's not it.
Either way, she had a rub that you could hear. Mm-hmm. And I just it came up on the x-ray, and I actually had him go do the assessment with me. And I'm like, I should hear something, right? And he's like, yeah, you can hear it right here. And I had been a nurse for almost 10 years at that point, but I knew that his assessment skills were better than mine. Mm-hmm. And so I'm like, you tell me. And also with doctors, I've historically, and I still do that. If a doctor puts in orders that maybe I didn't see or didn't do orders, I'll go and ask them, what was your assessment? What did you see? What did I get wrong? Mm-hmm. You just have to keep putting data in to even out that process.
Right. So, yeah. Yeah. I think that we still do that, right, with each other, is if you have a super sick kid, you'll even say, you got to go listen to that kid. Yeah. And it's because we know that it's important to continue getting that feedback into your brain of like, that's sick and you should listen to it, or you should see it, or whatever. And I do that with like our nurse techs or our newer nurses too, of, hey, have you seen a sickle cell crisis? Go in there and assess that kid and ask where their pain is and what it feels like and all of that.
You have to have a gut. You have to either be born the kind of person that has a gut that you can trust and that you listen to, or you have to develop it. My best friend is like all gut, bless her, in a way that I sometimes don't understand, which I think is what has always endeared me to her, is she's just so confident in, this is what I feel in the world. This is how I interpret the world. This is the right move. What does she tell me? She's told me this for years. It cracks me up. She's like, Sam, if somebody doesn't want to be my friend, that's their loss, not mine. That's a them problem. And I'm always like, if somebody doesn't want to be my friend, it's because I'm the problem and I need to change. And I care what people think about me, but I struggle to trust my gut. And that's one of the things that nursing has really brought out in me, is that I don't have a choice. I have to be good enough at this job to act immediately on information that I haven't processed yet. Mm-hmm. And yeah.
So what do you do when the doctors don't act upon your gut? Because that is probably one of the most frustrating things that we can experience as a nurse. Having a gut feeling and then just sitting and watching nothing be done.
In the ER, it's different. In inpatient, it's much harder because your doctor isn't right there with you. So my experience working inpatient was that it was very, very stressful to have a patient that you felt like was deteriorating and then not get any orders for anything, or get like a 250 ml bolus when they have soft pressures. Honestly, you just have to do it. I think that's another part of nursing, is that you have to do what the doctor tells you. And then you do all of the symptom management around their orders that you can. Mm-hmm. You utilize your PRNs. And then again, you have to know your staff, because you need somebody else on your team to come and back you up in it.
For sure. And I think as a charge nurse, I get that a lot of, hey,
from me,
I'm concerned about this. From you, from a lot of people, I'm concerned about this and we're not doing anything. Can you come take a look? And I really appreciate newer nurses doing that, because I would say a lot of times I will go in and I'd say, yeah, actually, I'm not that worried, and here's why, and give them my thought process. Or if I go in there and I'm like, yeah, that kid looks like crap, then I can go and be like, hey, I really don't think that this kid looks good to the doctor. And then I'm the second person saying that.
Oh, I definitely misinterpret that. I don't need you to come and assess the patient necessarily. I just need you to get what I want out of the doctor because they're not listening to me. So that's what I like to utilize you for.
Yes. And I will probably trust your assessment and maybe I won't go reassess the patient. But if I have other people saying I'm not getting what I want, then I feel like I need to assess so that I'm not like advocating for something that isn't needed.
That's silly. That's true. That's true. No, that makes sense. In the ER, when you don't get what you want, you have so much more opportunity to save the not backslide, the slippery slope, that I'm a fan of natural consequences. You didn't want to give me what I want? Fine. Let's do this. I'm standing here and I'm going to save the day when what happens, like I said it was going to, but fine.
Okay. Well, and the doctor cannot control how we monitor. So if we're concerned and we increase how we are monitoring that patient, whether that means, putting them on full monitor, or I'm just going to stand at the bedside and wait for it to happen, then that's what we're going to do.
There is one provider that does control how we monitor people.
But Chris Rochelle does not like a pulse ox on a bronchiolytic kid. I know that.
Well, he'll just straight up turn off the monitor on my seizure patient because he feels like we're done taking vital signs and that's not his job. Don't.
And then I go behind him and go, on.
Yeah. Yeah, that's exactly what he went to discharge. And I walked in, I'm like, why'd you turn the monitor off? Well, because we're discharging him. Super. I still need discharge vitals. Stop touching my stuff. Touch it
off.
Oh, okay. So as I know, not doing exactly patient care, one of the things that we like to do, obviously, is in the ER, we get a sick kid, we start interventions, we get a sick patient, we start interventions, we start to improve them. Mm-hmm. What happens when that's not the case?
When what we're doing doesn't help?
Yeah. How does that feel?
That's frustrating. And a little bit, it's not working, guys. Yeah.
What do you think the percentage of patients that happens, that's our case scenario is?
Oh, small.
I think so too.
I don't even think like one a day. I think that majority of patients, we usually have clinical pathways, which I'm not going to talk badly about our hospital, but a lot of hospitals have excellent clinical pathways for multiple diagnoses. So, if you have an asthmatic, you're going to follow this clinical pathway and this is exactly what you're going to do. And if this goes wrong, you do this. And if this goes right, you do this, blah, blah, blah. I would say for the majority of patients, they will follow that clinical pathway and they will get better. But there's that handful of you can do everything right and they're not improving. And then it's a slippery slope, right?
It is. It's a super slippery slope. And I think that my point in that it's not our norm is that we have to be so much more conscious of it because it is out of the norm, where everything else becomes so automatic for us. Looking at patients, just getting feedback that we can't even really articulate, having a gut, all of that is so routine because we reinforce it through our numbers, that a rapidly declining patient is not something with intervention, not something that we experience often enough that I think we can go on autopilot for. And I don't think it's acceptable to be okay with that. Like to be okay with not catching those things and not jumping on it.
And I think that's probably the reason why getting a full assessment in the beginning is so important. Not just like I look at you, I bless you, and I write my triage note, and I'm guilty of that, of the first time I see the patient not doing a full head to toe if they're just there for a fever,
Yeah.
But there's something to be said that if you haven't gotten that full assessment on them, when they do decline, you don't really have anything to base it off of. Like, is their pulse or is their cap refill different? I don't know. Did I check it an hour ago? Or are they, having retractions? I don't know. Did I lift up their shirt and actually look at them an hour ago? Like we can look and say they look worse, but I need to know why they look worse. I think that you're going to be able to focus your treatment a lot better if you have that like ongoing assessment. Does that make sense?
Yeah, of course. You need to have those tools to be able to communicate it. I think that dang it. I had something that I wanted to say. You said something good. And then I was like, that's exactly it. And now turkeys.
It's okay. You worked last night.
I forgot what it was. I will say I like a good circling the drain.
Oh, yeah. It's like a little puzzle.
It is. Yes. It's frustrating in the sense that if I'm tired and it's been a long shift, I'm very frustrated by the fact that what I'm doing isn't working. And I know that probably sounds horrible to people that don't work in the medical field, but
like, I'm tired. Can you just get better now?
I know it is. It's so true. I'm like, oh, why is this so difficult? Like I just need it to go like it's supposed to go. Mm-hmm. But sometimes it's fun. I mean, because when you get a code or a trauma from EMS and they've already put the line in and they've already done everything and you're like, but then you get like a abdominal pain that turns into like a septic perfed appy. And that takes a good like 2.5 hours to really start turning into crap. You're like, oh, sweet. Could I say that it's sort of like boogie boarding? You just want to stay right on the edge of the white water. Like you don't want to get overthrown by the wave because then you didn't do your job and your patient's in trouble. But I want it to be just a little bumpy. Like I want just a little work to do.
Yeah.
It can be kind of fun.
It can happen so fast. And I am going to say that I'm a bit of a stickler for a good blood pressure. I know in peds, we don't always like focus on the blood pressure, but if I have a sick patient, I better be running that blood pressure every 5 minutes because that's going to tell me real quick when they're
5 minutes.
If they're getting really sick, heck yeah.
No, 5 minutes if they're already sick.
I don't know. That I have seen that blood pressure tank like real quick.
I ain't never seen you run blood pressures every 5 minutes on a like only slightly unstable child.
I'm not saying only slightly unstable. I'm saying when my gut is saying they're going down.
Fine.
Because that's when I'm going to be able to tell the doctor like, okay, their pressure is now 50/20. You want to do something?
5 minutes is 5 minutes is like how often it takes to get one blood pressure out of a child. I feel like. So
if they're not stable, that's not true because they're not fighting it.
Because they're not fighting. Oh my gosh. Isn't that just like the most pick you answer ever? I remember getting that in training. It's like, you can get a good blood pressure on any child and you shouldn't shop around. Like, shut up. That's because your kids are intubated and sedated. Like, no, if I was running around screaming in the room, you couldn't get a good blood pressure on me either. So
yeah, that is a little, blood pressures mean nothing unless you're laying still. And children are never laying still.
Yeah, with their arm at what's the name of that? The orthostatic, what's the name of the place that you have to have the blood pressure that is the middle of it's like you use it for art lines too. It's the middle.
The PMI? Is that what we're talking about? No?
Mortgage insurance? No.
I don't know. We are not doing well with our words today.
It's where you have to tape it to the bed so that it stays in the right place.
Yeah, you just put it at the apex.
No, there's a term for that. But anyway, you can't take a blood pressure on your 2-year-old that's asleep on their side with like their, arm up in the air.
Yeah, and you're not going to fix a blood pressure by sitting a patient bolt upright and putting a bright light in their face. Which is the real thing that happened.
That was so good that day.
That person no longer works with us, so I can.
Yeah, so feel free to bring your children to us because she's not here. So
yeah,
it's okay. Yes. Oh, when you're talking about having actual like data, that is why I don't feel like it's appropriate in our department to not have a full set of vital signs every 2 hours.
Oh, absolutely.
Unless they're admitted or discharged, like their status hasn't been like, I feel like legally determined yet. And so they're always able to deteriorate. So,
Yeah.
other things, is there anything? I don't know. I just feel like a rapidly declining patient is fun. I like getting the provider in there. I like getting the team in there. I like that it's a little bit messier than a code, which is so prescribed.
Yeah.
But you get almost like a ROSC patient where you're like, now I have to get my sedation going and I need to get my pressors going. And
Right.
you do the fluid bolus, but you have to be, and we do it all in our training classes, but it's fun when you actually get to apply it, because usually we give a bolus and the patient gets better and we kind of move on. But in those patients, you actually have to be looking like, are they getting better?
Reassessment.
Yes.
Reassess. That's when you're like saying, somebody get the airway cart and put it outside this room, because I'm not sure which way we're going.
Well, and you bolus them and you're like, did they actually get better? Did I just flood their lungs? Oh, wait, I have to use my stethoscope to find that out. Like, let's go. Let's do it.
Well, and something a doctor said to me the other day is that there was a patient that was really not doing well. And a nurse came and said, hey, can you come take a look at this patient? But not with a whole lot of urgency.
Oh, Lord.
And she's like, I need to know, like, if you're going to come and ask me to take a look at a patient, I need to know, like, does that mean get up and get here right now? Or I have some time. And I feel like the doctors know that if I walk out of a room and I'm like, hey, I need you in here, they're getting their butts up like right now, because I don't overuse that. I use that when I actually need you. So we've talked about before that sometimes we have some nurses that cry wolf and talk to the doctors about everything. I feel like when you really need a doctor, you don't want to be the nurse that has cried wolf 100 times. Like, you want to be like, I need you now. And they understand that that means it's go time.
Yes. Yeah. I don't think that you're wrong in that. I think that it also goes, well, you're saying cry wolf, which would be like you oversell everything, so they don't really know what is actually sick. But I think that the scenario that you gave is actually the opposite, where they undersold, which is
right. But I think in the past they had oversold, so that now when you have an actual sick patient, they're like questioning you, like, well, do you really need me right now? And then they walk in there and they're like, oh, this baby's almost dead.
Which goes to your, I don't know, which I think goes to using your gut. I know a few years ago, early in the morning, this poor doctor was finally getting to go eat. And she literally walked by the room with her food in her hand. And I popped my head out and I was like, I'm so sorry. I need you to put it down and come in here. And afterwards I was like, I'm sorry that I like accosted. I didn't like yell at her or anything, but I was like, I need you to put it down and come in now. And this poor child had a ruptured bowel, but she wasn't dead yet. And so it was just like my gut, where I was like, I think that I need the provider. And so I went to her afterwards and was like, I'm sorry. I know that you were trying to eat, but thank you for coming in. She's like, that's what we're here for. Don't ever apologize for coming and getting me like that. Okay. What if it's not your section?
Well, ultimately, I care more about the patient than people's feelings. So if I walk by and I see something that concerns me, then I will raise the alarm.
That's good.
That's just how it is.
Yep.
And I feel like we work with a really good team. I feel like most people, I mean, almost everyone I think will ask a senior nurse's opinion if they're worried about something.
Yeah, that's true.
And I feel like in a broader sense, that's where you're going to get in trouble, is if you're unsure and you're not asking anybody else. Because if you're at the point where you don't trust your gut yet, then you need to ask other people's opinions.
There's one worse step than that, though. which is not even knowing that you're in dangerous territory.
Yeah.
And that just can't be tolerated.
Right. But how do you teach that? I guess that's more of an accountability thing.
Yeah. From management.
Mm-hmm. When I just had that interview, one of the questions they asked me was like, how do you stay on top of latest evidence or your assessment skills? And really that is a self-accountability thing. Like you have to hold yourself accountable to being good at your job, knowing what you're looking for. And I don't know how we teach that self-accountability.
I don't like that. I don't like what you said at all. No.
Well, that doesn't surprise me. Go for it.
No. I actually did. I like what I learned when I was a young nurse. I think I rolled down a lot of hills and I got a lot of things beat into me and beat out of me. And I don't like changing practice, and I don't like changing I don't like that we don't do a lipase and an amylase for gallstones and gallbladder. I know that we technically don't need them both anymore. That makes me mad. I'm like, I just want both of them because that's how I used to do it. And if it was right then, why can't? So
you're saying that you don't want to stay up to date on why we do things? Is that what you're saying? I'm confused. What don't you like about what I'm saying?
I'm saying that I don't like the changing all of the time. If it was good when we did it before and that was right and that's how we treated patients, do we have to reevaluate everything all of the time? And I struggle as an older nurse that now the pieces of information that I've relied on to make decisions for years are perhaps now not the pieces of information that we're supposed to be looking at. And it's like, well, I did it for a long time and it was fine then. So now you're saying that I have to constantly change my practice. Case in point, the push dose IV antibiotics, just for Pete's sakes. We've been giving them over 30 minutes for a millennia, but now we can push them. Shut up and just let me give it over 30 minutes. If you can't.
Well, I don't think anybody's stopping you from giving it over 30
Pharmacy
minutes.
Did. Oh. They said the order was taken away. I know one of our nurses was like, then just give it over 30 minutes. Sam was like, but I charted that I gave it as a push, so I can't give it over 30 minutes.
Oh my gosh. Yes, I am with the other nurse that was rolling her eyes and saying, Sam, nobody cares. You're the only one that cares.
Yeah, well, that's probably true. So I think that, I'm not as ridiculous as to say that we shouldn't improve and find better ways. I don't like the shifting sand all of the time though. And I struggle with it because if it doesn't come from the organization or it doesn't come top down, then you have a bunch of independent actors all doing their own research and trying their own things. And we don't have any uniformity in what you're doing. And I don't like that at all. So that's why what you said stresses me out. To go back to the Zofran, it's like, no, this is how much Zofran we give. Well, where I came from, this is how much Zofran we gave because of new research. Well, screw your new research. This is how much Zofran I've been giving forever. So,
and it treated nausea just fine.
Yes, exactly. And no one's going into the prolonged QT. So why are we having this dumb conversation?
Yeah.
So I disagree with you on that.
Okay. Well, that's fair. I'll let you.
I'm trying to think of other things.
We just had we had this argument about compazine the other day because compazine supposedly is not compatible with normal saline.
I brought this up to a pharmacist for you,
but you have to give it over 5 minutes. So how are you going to give 1 mil over 5 minutes and all the things, right?
Mm-hmm.
And one of our rule following nurses, she was the one that was adamant. She's like, what do you do? And I'm like, me and other nurses have been giving it over 5 minutes for 20 years, or have been giving it in normal saline. So it's compatible. And now if you look at the new research, now it doesn't say it's incompatible. It says not conclusive or something like that. So I'm like, is that good enough for you that it says inconclusive and now we can just do whatever we want? I don't know.
Yeah. Oh, that's what I was so the ChloraPrep, that's a new thing that I don't care for at all. Just give me alcohol. Alcohol's been working for years.
I know you were so sweet and set up my IV cart the other day, but you put an alcohol swab on there and not a ChloraPrep, and I didn't say anything.
You should have.
You put one alcohol swab, and I scrubbed that kid's arm, and the alcohol swab was like all dirty, and I'm like, well, now I need more.
Well, the ChloraPrep would have been dirty too, right?
Yeah, I know, but it gives you more liquid. I feel like it's like I get cleaner with it. Plus, I can use the tip of it to make my spot of where I want to poke, because that kid had like a deep vein.
Oh, I guess some of us just know how to poke and don't have to put marks on our kids. So.
Samantha.
Speaking of that, there have been a number of crashing kiddos that we've had. And while we were thinking of talking about this, and I was like, oh, I'll have to tell some stories. Having fun and being fun in those situations and enjoying what you do and having skill is really good. But to the ChloraPrep point, I did chuck one at somebody. I think we were in room 19? I can't remember what room we were in, but it was this crashing patient and I needed a line, and the nurse had already missed. So she was manning the cart for me while I was starting line, and she freaking handed me that like open ChloraPrep so that I could grab the wand, and I just pulled it out and threw it right back at her and said, I want alcohol.
That doesn't surprise me.
And she's like, huh? I don't use that crap. Give me an alcohol swab.
You're so weird. But see, maybe you need to change, because I feel like you're the only one using alcohol. You're the only one.
That can't be true, because I'm also the only one that's stocking the IV carts at night, and I always have to put alcohol in them. So somebody's using it.
Because you want to know what we use the alcohol for? Is to scrub the top of the blood culture tubes and to scrub our med bottles. We don't use it on their body.
I'm sorry. You scrub what do you mean med bottles?
Like if you pop a Zofran.
You lying fiend.
I don't.
Do not.
But I don't do it, but you're supposed to. And I see nursing students do it all the time.
Okay. Again, another thing that I'm like, for decades, we have been popping that thing off and giving people drugs. Shut up. Now I have to scrub it with an alcohol. Oh my God. It just kills me.
No, or you scrub your med ports on your IV tubing. I do scrub those. That's what the alcohol swabs are for. They are not for people's skin. Nobody does that. You are the only one.
That is such a lie. That can't possibly be true.
Maybe our old man nurse friend. Maybe he does, but we'll do it. Okay. Well, anything else about the rapidly?
I don't know. I think
we went a little awry, but I think
we missed the mark for sure.
I think the biggest thing is that you like just recognizing sick from not sick is just absolutely necessary.
And it is 100% unacceptable to not look at your patient.
And it changes quickly. Like the sick, not sick, sick, not sick. Every time you walk in the room, you should be like looking like, do they look better? They look worse.
Oh, yeah. I thought you were going to they flip-flop from looking sick and not looking sick. I was like, not usually. No, they usually progress in one direction or the other.
Yeah, like a continuum, right? Like, which way are they going?
Yes, but I mean, I would like to reinforce that it really isn't acceptable to just not look. I think if you look and you get it wrong, that's a different conversation. Because we have all done that and we have all been there and we have all missed the mark. But to just straight up be lazy and not look at your patient and not do what they have come and requested of you and that you're supposed to be doing and serving them in that capacity, that's absolutely unacceptable to me. And that is the hill I will die on.
And I think why it happens is we get jaded. And I think we see so many fever patients over and over and over and over again that you get to the point where you just assume they're all fine.
Mm.
I'm not saying it's the right thing, but I think that's what happens. I think that we get jaded. We start to pigeonhole patients.
Mm.
And it takes one of those that you missed getting really sick to like slap you in the face to be like, oh yeah, this is my job to assess every single patient, whether I think they need it or not.
I think that's I like that. The slap in the face patient. That I actually sort of love that image because that is exactly what it should feel like. And it does. I mean, we've all, especially early in your career, you go from like being terrified of everything to thinking that, you're too big for your britches. And then, what is it, like year 2.5? I think that's about where the slap usually comes. And you're like, oh, frick.
I don't know what I'm doing.
I don't know. Oops. I am not as cool as I thought I was.
Yeah. It still happens where I assess something one way and I totally missed something.
No, but that's different. That's what I'm saying. That's not the same thing. That is a different conversation. It's when you don't do the assessment that it's an unacceptable. It just can't be it. I do not think that it can be tolerated. It's just not, it doesn't allow the environment to exist in the way that it does when you're having to manage that kind of behavior on your unit. And but I'm the meanest, scariest nurse. We had this conversation again last night that I don't smile enough. And that I'm too intense. So.
Well, who thinks I guess we can't say names, but you'll have to tell me later who thinks you're the scary nurse now. I don't think you're scary. I think you're a little ridiculous. I think there's a difference.
Well, on that note,
that's what I tell people when they think you're scary. I'm like, she's not scary. She's just ridiculous.
Oh, well, okay. I don't think I like that anymore. I don't, as a one, oh my gosh. And then everyone was looking at me like I was psycho because I was like, what's your Enneagram? And all of the Gen Zers were like, an Enneagram what? So,
yeah. Well, we're going to have everyone take their Enneagram test because we're going to do an episode on that, on how nurses are as different Enneagrams.
Yeah, I tried to get them to do it, and then they had to put their email in at the end, and so that wasn't worth it to them. So,
doesn't everybody have like an email they don't open that they put in for all those things? That's what I do.
I don't know what they do.
You can just have an email on anything. Just make up an email address. And then that's where you send all that nonsense.
I think all my Apple stuff has like a hide my email.
Yeah.
Right. Okay. Well, I do want to say that while our tagline is that it's not about the patients, this was a little patient-y, but I think that's okay because we're doing like a sort of skills thing. And this is the last one. We're going to move into something else. And after this episode and kind of get back to more social aspects. I really we really need to talk about break room etiquette. I think that the world needs to know.
Yeah.
That there are rules.
Yes.
You need to stop.
If I have my earbuds in, don't start talking to me. Please. I'm in the middle of watching Biggest Loser documentary on Netflix, and I need to know what's happening. And if you just walk in and start talking to me, then I have to be polite and take out my earbud and have a conversation. But yeah.
And that's just the tip of the iceberg in the break room. Okay. We have time for some questions. Yeah.
Yeah. Okay. Well, this kind of goes with what we were talking about.
Okay.
Do you believe in manifestation? Like you can manifest like positive vibes.
Not in the way that you're meaning. Not in the what is that term? Prosperity gospel.
Oh, yeah.
No, but I think that when you're going to get me on one of my segues and you're not this is why people are going to think that I'm psycho and not.
No, this is why I asked the question because I knew that you would have something to say.
When you orient yourself to like the greatest good and you are making those decisions, then it is just inevitable that that is how you see the world. So you like literally can't take in all of the data that is available to your senses all of the time. And so you have to pick and choose which ones subconsciously you are going to see and act on and make reality, right? That's why like we can only focus on one thing at a time. We see lots of stuff, but we can only focus on certain things. So if you change how you're interpreting the data that you're bringing in and you orient yourself to the greatest good, it's not that bad things don't happen. It's just that your actual interpretation of the physical data that you're taking in is different. So I don't think that you can manifest good things, but I think, yeah.
No, I totally agree. I think that when you are, and I feel like that's probably what people actually experience when they say like manifesting like good vibes. It's if you're putting good vibes out, you're going to get them back, or you're going to focus on that. You're going to see goodness. But if you are focused on all negativity, that's all you're going to see.
Do you know what I don't find helpful in that, though, are people that wear T-shirts that say, be a kind human. Don't tell me what to do. How about you be a kind human? And then we'll go from there.
I have a T-shirt that says, don't let idiots ruin your day.
That's a different message than someone's shirt telling me how to behave towards them. No.
My best friend has a shirt that says, mind your own motherhood. And I love that.
What does that mean?
Like, don't judge how I parent.
Oh, okay. No, I like truly didn't understand. I'm like, oh, do I need to remember like what my mom, like the things that my mom taught me, like mind my own. Oh, so does that mean that if I
mind your business,
like mind your business? I was at a swim meet and I sat next to this mom that got on to her daughter. Finally, they were doing something. She's like, but so-and-so was doing it. She's like, you know better. And if you do it again, I'm pulling you out of there and we're going home. And I turned it and I looked at her. I was like, you don't need my validation, but I just want you to know that I agree with everything that you just did and good for you.
No, that is absolutely true. Yeah.
Yes. Oh, turkeys. Okay. So, have I asked you, I don't think I've asked you this. Is sneezing risky or not risky?
For me, absolutely risky because I pee a little bit. So if I feel like a sneeze is coming on, I either need to sit down or I do like the little lean and clench.
Yeah.
You know?
Mm-hmm. I can't be mid-step. It's
yeah.
No. Yeah. Okay. Well, that one was easy.
That's easy.
One. I have other ones.
What color do you think best describes your personality?
Kelly, what? Colors don't have personalities. They're just colors.
So beige.
Shut up. You're ridiculous. That's not even nice. A few years ago, I bought a rug at Costco without telling Philip, and I shoved it in the Prius, and I was so proud of myself. I was like, babe, I bought this rug. It's totally fine. He's like, okay, whatever. I'll see you when I get home. And I was like, but don't you want to know what color it is? And he said, it's beige. And I was like, yeah. He's like, yeah, because everything you buy for our house is beige. And I was like, shut up.
That's amazing, Philip. It's beige.
And it was. I mean, I would say that it was cream, but I mean, technically speaking, yeah, he was right. So I guess I'm beige. Thanks.
Oh,
what color? What?
But you like being beige, right? What color do you want to be?
Oh, I don't want to be a color.
See,
that's too much. I don't want people to look at me. That's no.
I think I'm like every color. It depends on my mood.
Which is also not an answer to the question. So that's great. So can men and women be friends?
We already had this question.
Yeah. And then we re-recorded the episode. So.
Oh, really?
Yeah.
Oh, okay. Then I'll answer probably the same. Who knows? No, which that is, I think I said this last time. Yeah. A lot of people might be surprised by that answer and it might get me some backlash, but Yeah, yes, they can be friends if you're not married. But I feel like once you get married, I feel like, oh, like the title of our podcast, I feel like that's a slippery slope, and I feel like that can cause a lot of unnecessary drama between a married couple. I cannot imagine we have couple friends where, he's friends with the wife of the husband, or we'll travel together all as couples, things like that. But I can't imagine like my husband just having a female friend. I feel like I would question what he wasn't getting out of our relationship that he needed to get from another female.
Okay.
And I don't know. I'm a redhead. I have a jealous streak. That's it.
I feel like I have the exact opposite opinion. I feel like if you...
Which probably surprises everybody. They probably would expect the opposite between us.
Yeah, because I have like social structure and expectations, and you just think everything's okay. And no.
Yeah.
I think that it is more socially acceptable if you are both married to be friends, because I feel like it like fills your little electron cloud, so you're not searching, and so that kind of like I feel like brings a safety net too. I will say I don't think that you can have a male friend as a female that is the same as your female friends.
No.
But I think that you can like socially have friends that are men. And of course, there are topics that should be off limits. Like you shouldn't be talking about your spouses, and you shouldn't be talking about like certain things that you would talk with women about. But I think that it's okay to have male friends that.
Well, and I have male friends, I guess, that I work with, or, like I said, that are couple friends. But we're not like hanging out one-on-one. Just the two of us. Like, I don't know.
But you text them.
Sure.
Yeah.
Yeah. I guess it's just on a different level.
Yeah, it is a different level. But no, I think I don't know. I think it's okay.
Okay. So one more?
Yeah, if you have one more, I have one more, but I can't remember my answer to it. I feel like I had a good answer. And so I wanted to hear what your answer was. And now I can't remember what it was.
If animals could talk.
Okay.
Which species do you think would be the nicest?
How do you come up with this crazy stuff? Oh my word.
These are the things I think about. Well, you have to talk it through, right? Like, because like house cats, they would not be nice.
But they would be my favorite.
Right. Which would be the nicest?
I don't think bunnies are nice. I don't think birds are nice. I mean, I guess it's got to be a dog, right? Yeah. They're kind of dumb and happy.
Yeah. Dumb and happy.
Dumb and happy. Except for pit bulls. No.
Yeah.
Can't be around pit bulls. Okay. My question for you was, what was your most embarrassing high school moment? And before you answer, I want to tell you that the 4 years that I was in high school, I think I was probably embarrassed myself all of the time. And I just presently can't remember what the most embarrassing thing that happened to me was. But yeah.
Honestly, I block out any negative.
Oh my gosh. Okay.
I don't think that that's a good thing, but I try not to like focus on that. I will tell you an embarrassing memory that like sticks out, but I'm not sure if I was in high school or not, but I was at a funeral, and it was like a Catholic funeral. Like, I have a lot of Catholic family. And so I had hay fever, and I was like sniffling, and my dad told me to go to the bathroom and blow my nose. Mm-hmm. So there was this open doorway, and then there was 2 slats on either side that also appeared to be open, but were glass. And right while they're like doing final rites and doing all this stuff, I walked smack into the glass, and the entire like Catholic thing turned around and stared at me. So
the whole like body of people that were there.
The body of Christ all saw me in all my glory.
Did you fall down?
No, but I did get a bloody nose, and then I didn't come back in. I like hurried out, and then I just sat in the lobby or whatever it's called.
The foyer.
Because I was too embarrassed to go back in.
Oh, okay. I do remember mine, but mine's, I feel bad for you. People run into like glass doors all of the time. That's not.
And it's hilarious watching people do it.
It is.
But in the middle of a funeral, it's something else.
Yeah, that's not great. I had a boyfriend in high school that was a Boy Scout and went up to like a camp, and his mom took me up there to visit him because he was like up there all summer. And it's like 1,000,000 degrees where we grew up, and it was going to be 1,000,000 degrees up there. And so of course I wore my Daisy Dukes because, I mean, people only like me for certain reasons, and I'm pretty sure that's mostly why he liked me. So those are the ones that I wear. Nobody counseled me as like a high school girl that maybe I should put pants, like properly lengthed pants on. And so we got there, and he convinced me to do the ropes course above everyone. Oh. I know. And it took me years to realize how horrible of a mistake that probably was.
Did you have a whole bunch of people standing below you watching?
I just remember there was a lot of like boys that were like laughing around, and I didn't really think anything of it at the time. And now I look back and I was like, oh my gosh, his mom really didn't like me. And I feel like she had the opportunity to be a really lovely older woman to a younger woman, and she really missed the boat there.
Oh, I just thought of a high school one now that you said that.
Okay. All right, go.
My current mother-in-law.
Oh.
So me and my husband were high school sweethearts. We broke up a little bit during after college and then got married later. But he was a year older than me. So the year before my senior year, he was going to college, and I drove over with his parents to drop him off in the dorms.
Okay. Ooh.
I then had to ride back home with his mom, my now mother-in-law, who I love dearly. She had a full conversation with me about how I should not get pregnant on purpose to trap her son.
Who are these psycho people? Oh my gosh.
And this was like, it was like a 6-hour car ride. And what? I just had to sit there because she and my father-in-law drove separately. And so I rode home next to her the whole time. And yep, she let me know at 17 years old that I should not get pregnant to trap him.
Oh my gosh. Kelly, I don't feel like, for one, that's not embarrassing for you. Like, I publicly embarrassed myself. So thank you for not at all matching that energy. I think you were like a little bit harassed, like a little sexually harassed. I feel like that's like you were a minor, and that was a way inappropriate conversation to have.
I was just like, I'm not going to do that, but thanks for letting me know how you feel about me.
It's not okay. You have all boys. Will it be okay to talk to your daughter-in-laws about their intimacy with your sons? I don't think that's something that I'll delve into. I think that is not, not appropriate.
I think I will, but that's because I talk about everybody. I talk to everybody about sex. So that's not a weird conversation for me. But I will not probably do that.
I might talk to them if they like have concerns about like their like female bodies. Like, you think that has to be really open and available if that's what they want. But I can't even think about it right now. Oh no, I don't like this. We need to go somewhere else. This is not going to do. This is no. Well,
that's okay. No. We're out of time anyway.
We're out of time anyway.
On
Great
that note.
Well, hopefully we picked it up there at the end. All right. Well, thanks for hanging with us. Check us out on socials. We're trying to do better at it. It's not our forte. So leave us like at least a review. Some text on there would be great, or a thumbs up or something. But otherwise, we will see you next week at the Nurses Station.
Bye.
Hey guys, this is Kelly from At the Nurses Station. Sam and I would like to remind you that the views and opinions expressed on this podcast are strictly our own and do not in any way reflect the position of our employers. This podcast is for entertainment purposes only and in no way should be considered medical advice. As always, consult a qualified medical provider for questions regarding your health or medical conditions. We hope you had fun listening to us today, and we'll see you next time at the Nurses Station.